Hello, today I will be presenting my project, the effects of EGFR mutations in tumors on the outcomes of an abscopal effect. Before I begin, I would like to thank Dr. Kerba and Dr. Abedin from the Tom Baker Cancer Center for mentoring me throughout the course of this project. First, a little bit of background. Lung cancer is the leading cause of cancer-related death worldwide, with a 17% likelihood of living 5 years or longer after being diagnosed with the disease. Non-small cell lung cancer is a specific type of lung cancer that is grouped together for similar treatment options. Adenocarcinoma is the most common form of non-small cell lung cancer, and it originates in the mucus-secreting glands of the lungs. There are many different types of treatment for lung cancer, including radiation therapy and chemotherapy, but the treatment option that has taken the forefront of cancer research as of late has been immunotherapy, which utilizes the body's own immune system to target cancer cells rather than attacking them directly through the use of chemicals or radiation. One example of immunotherapy would be immune checkpoint inhibitors. Essentially, there are these receptors on the surface of the cell that allow the immune system to recognize the body's cells as part of the body and not part of an invading bacteria or other type of cell. However, cancer cells often mutate to have an abundance of this type of receptor, which causes them to be effectively cloaked from the immune system. Inhibitors such as ipilimumab, pembrolizumab, and nivolumab can block these receptors and allow the cancer cells to be recognized by the immune system and cause the immune system to launch their attack. Another form of immunotherapy is through the use of EGFR tyrosine kinase inhibitors. Essentially, there are certain genes that cause the unchecked cell reproduction that characterizes cancer when they have become mutated. One of these genes is the EGFR gene, which produces a protein of the same name on the surface of the cell that when it binds with another protein on another cell causes the cell to divide. Inhibitors can be used to block these receptors to prevent the cell from dividing at such a rapid rate and allow the immune system to attack the tumor without fighting an uphill battle against a constantly reproducing cancer cell. All of these different treatment options are for the sole purpose of preventing the spread and the effects of cancer within the body. Essentially, it is for the production of an abscopal effect, which is the use of localized treatment to cause system-wide results. This is through the release of damage-associated molecular patterns and the presentation of tumor-associated antigens on the tumor cells that alerts the immune system to the presence of cancer within the body. However, this does not happen frequently, as the immunosuppressant effects of the tumor prevent the immune system from detecting it as easily. As such, the objective of my project is to determine whether or not the EGFR oncogenic mutations will have a substantial impact on the outcome of an abscopal effect in a non-small cell lung cancer tumor treated with immunotherapy. So the variables of my project are, for the independent variable, it is whether or not the patient has the EGFR mutation. If they are EGFR positive, that means they do have the mutation, and EGFR negative means that they do not have the mutation. The responding variable is the outcome of an abscopal effect, but this is difficult to quantify. So in order to determine whether an abscopal effect occurred, I'll be looking at general outcomes, which include overall survival, or how long the patient survived after being diagnosed, and progression-free survival, as in how long the patient survived after being diagnosed without the cancer getting worse or metastasizing. Some of the controlled variables include where the patient was treated. They were all treated in Alberta. The type of cancer, which was all non-small cell lung cancer, specifically adenocarcinoma, and the amount of lung cancer primaries, which was only one. There are many contending variables, as the human body is very interconnected, but some include age, as the minimum age was 18, and the stage of cancer, which could vary from stage 1 to stage 4. So the hypothesis of my project was that a patient with non-small cell lung cancer who is EGFR positive and treated with immunotherapy would be less likely to have the abscopal effect occur. And this is due to a variety of reasons, including EGFR positive patients having increased chances at a reduced overall survival, an increased chance at lymph node metastases occurring, as well as a reduced sensitivity to chemotherapy. Additionally, any benefit that may have been gained from EGFR-specific therapies is quickly lost as the tumor gains resistance. For methodology, 339 patients participated in a retrospective cohort study at the Tom Baker Cancer Center here in Calgary and the Cross Cancer Institute in Edmonton. All data was recorded from the Provincial Medical Records, ARIA-MO, and all received immunotherapy between 2010 and June 1st of 2019. Later, between July and October of 2019, Additional data was recorded for the dates of discovery of various metastases within these patients, including brain, bone, liver, and other metastases, primarily including renal, adrenal, and intrathoracic metastases. To analyze this data, it was all compiled into an Excel spreadsheet and then analyzed using the statistics program SPSS. The patient numbers were reduced to 239 to account for the controlled variables, and of these 239, 13 were EGFR positive. The means of overall survival and progression-free survival were calculated and determined whether or not to be statistically significant. The rates of percent for overall survival and progression-free survival were graphed, and EGFR status was compared against different occurrences of metastases and determined whether or not to be statistically significant. First, we'll look at overall survival. As you can see here in this chart, there was a difference of 79 months, or around 6.5 years, between the EGFR positive and the EGFR negative group, with the EGFR positive group having a lower on average overall survival. You can see that here demonstrated in the graph, as the percent overall survival of the EGFR positive group in red decreases at a much faster rate than the EGFR negative group in blue. Next, you can see here in the progression-free survival that there was around a 4-month difference between the two groups. However, this was not shown to be statistically significant, which essentially means that it would not occur in the general population. This is further demonstrated here in the graph, as they almost line up perfectly, aside from the jaggedness of the red EGFR positive line due to the small sample size. Lastly, here you can see the comparison of metastases and the EGFR positive status. First, for brain metastases, there is a difference of 41.8% between the two groups, with the EGFR positive group being more likely to have brain metastases occur. For bone metastases, there was a difference of 28.7% between the two groups, with again the EGFR positive group being more likely to have bone metastases occur. For liver metastases, there was a 24.6% difference between the two groups, with the EGFR positive group being more likely to have this occur. However, it was not shown to be significant quite yet. It was just above the line of statistical significance. This essentially means that it's trending towards being significant, but it would have to be studied in a future experiment in order to be determined whether or not to be exactly true or not. Lastly, for other metastases, you can see there was a 1% difference between the two groups, but this wasn't shown to be significant. So basically, my hypothesis was supported, as in patients who were EGFR positive were less likely to have an abscopal effect occur. This was shown in the lower on average overall survival and the increased rates of brain, bone, and perhaps liver metastases. This has been supported by studies in the past, as patients who are EGFR positive have been shown to have less of a response to immunotherapy, regardless of whether or not they have been treated for EGFR specifically or their immune checkpoint expression. Additionally, the tumor microenvironment of EGFR positive patients is unique in that there are fewer tumor-infiltrating immune cells and there is a smaller tumor mutational burden, essentially meaning that it appears closer to the body's own cells and allows them to hide from the immune system for longer. Additionally, radiation therapy is generally known for destroying cancer cells and releasing damage-associated molecular patterns and presenting tumor-associated antigens, allowing the immune system to recognize the cancer within the body. However, in EGFR-positive tumors, it has been shown that radiation therapy can promote proliferation of cells, causing an increase in size of the tumor, and the avoidance of apoptosis or natural cell death, causing the cells to live for longer. Lastly, brain and liver metastases have been correlated in the past to occur more frequently in EGFR-positive groups. However, to my knowledge, there have been no studies in the past correlating or attempting to correlate bone metastases with EGFR-positive status. So in the future, in a future continuation of this study, it would be important to include a larger, more equal sample size, as the EGFR-negative group was composed of 226 patients, while the EGFR-positive group only had 13. This caused a lot of noise within the data itself, but unfortunately was unavoidable due to the fact that the data set was actually catered for a different retrospective study. The inclusion of a more equal sample size would allow for a more clear distinction between the various data points. Additionally, a clinical study over a retrospective cohort study would be important, as it would allow for variables to be controlled more easily, as well as additional information can be recorded that might not necessarily be written down in an average course of a cancer treatment. So why is this all important? Well, in 2018, there were 18 million new cases of cancer worldwide and 9.5 million deaths caused by cancer worldwide. 11% of these new cases and 18% of these deaths were lung cancer mediated. Additionally, low survival rates and delays in diagnosis of lung cancer specifically have caused this form of cancer to be especially insidious. As such, understanding the mechanisms of cancer overall and how to produce the abscopal effect is immeasurably important and can be extended to other forms of cancer as well. Thank you.